Hi, my name is Ben Atkinson and welcome to the Functional Health Podcast. I interview some of the leading voices in nutrition and lifestyle medicine, and I will share with you their stories, their expertise and their advice, shedding light on the industry from each of their perspectives to help improve your health from today. This week, I'm delighted to share with you my conversation with Professor Shumone Ray, and today we talk about the importance of linking nutrition research, policy and practice through evidence and education. This is quite a technical episode, but if you're interested in public health as a doctor, researcher or nutritionist, this one is for you. So, without further ado, Shumone, welcome to the show.
Thank you, Ben.
It is such a pleasure to have you on. It's been a long time coming, I would suggest.
Yes, indeed. Very pleased to be here and to be able to share little snippets from my perspective and that of the NEB Pro Global Centre.
Absolutely, and there is a lot to speak about for sure. But I would love to, just for context, and I think just to orientate the listeners, to learn a little bit more about you and what got you into this nutrition space in the first place.
Sure. So I'm often asked this question, as you can imagine, especially as I'm a medical doctor as well as a registered public health nutritionist. But really, I was a unicorn from the beginning, if I might say that, because I did an intercalated degree in nutrition and then undertook some extended nutrition research as a medical undergraduate, and sandwiched my nutrition degree and research in the middle of medicine. That took me to rural Nepal for a couple of years, where I studied the big four nutritional deficiencies in a Tibetan refugee population in the Himalayan foothills, and focused particularly on iron deficiency, anemia in pregnant and lactating mothers. And that really catapulted me into a position where I graduated as a medical doctor and became a public health nutritionist at virtually the same moment. And both have therefore stayed with me intertwined ever since.
That's incredible. And in Nepal, is that quite prevalent, iron deficiency, anemia in pregnant women? Just to dive into that a little bit.
So indeed, it is prevalent. And to give you context, so I qualified 20 years ago, and the time when I was doing research was almost a quarter century ago, but it is indeed puts a number on my age. But the big four nutritional problems at the time were mainly iron deficiency, anemia, protein energy, malnutrition, iodine deficiency, and vitamin A deficiency. We've seen a sort of reduction in the incidence and prevalence of iodine deficiency. But interestingly, iron deficiency anemia is still highly prevalent and very brittle, and is a long-term problem that now requires different solutions to the ones that perhaps haven't worked so well over the last couple of decades. So long story short, some of the things from 25 years ago are still just as relevant, but we now know what works and what doesn't, and therefore there are opportunities to do different.
Right. Okay. That's really important. And I guess iron deficiency is one of those where I don't think it's looked at enough in a way. I remember reading a paper looking at iron levels and IQ, for example, in growing children. So it's hugely important. And I'm not sure the dietary quality out in Nepal either. Do you still see instances of kwashiorkor and things like that? Or is that less?
Well, protein energy malnutrition in all of its forms is still a major problem in most low to middle income countries. at both ends of the age spectrum. So yes, it still is a problem. There have been some changes in the patterns and distribution of protein energy malnutrition, but we also know that it's part of the double burden even in the so-called developed world. So it's unfortunately just as much of a problem as it ever was. But as I say, with sort of changing form, and we now have a few more insights and solutions than we did before.
Yes.
So a lot to do still, but we know a bit more about how to perhaps approach it.
Right. Okay. Well, that is certainly a positive, I think. If anything, we've got some better interventions. Now, shifting slightly, you ended up, throughout all of this, you ended up founding NEB Pro, I believe in, and correct me if I'm wrong, Shumone, but 2008 you founded NEB Pro?
That's right. So NEB Pro stands for the Need for Nutrition Education and Innovation Program. However, in 2008, it was founded as the Need for Nutrition Education Project. Nowadays, we don't expand the acronym. We simply refer to the NEB Pro Global Centre for Nutrition and Health, which is sort of a representation of how we've evolved from project to program to a global centre. But going back to 2008, that's correct. That is when it was officially founded.
So it is amazing how it's evolved, and just looking at the history, even in the last few years that I've been very happy to be involved and follow your journey. Who is NEB Pro for, and what does it do? What's its main mission or vision?
So NEB Pro is really quite diverse in terms of the individuals and institutions it involves and also targets. But going back to the beginning, so where all of this came from was really that over 2005 to 2007, I was involved in the UK division of the Council of Europe Alliance for improvement of nutrition in healthcare. That alliance took origin from quite a large number of recommendations coming out of the Council of Europe, which you'll know is different to the European Union, of course, as the UK still remains part of the Council of Europe. And those recommendations led to really a 2-year task and finish collaboration of multiple organizations from the public sector, from the third sector, and also from the private sector. That led to the establishment of the 2007 Nutrition Action Plan by the then Department of Health in England. And in that Nutrition Action Plan, there was just a tiny paragraph that said the Need for Nutrition Education Project will be formed as one of the outcomes of the task and finish work of the Council of Europe Alliance, and that was fully supported by the 2007 Action Plan. That then led to successful funding. So first funding came from the National Institute of Health Research, which was brand new at the time, and with some matched funding from industry partners and also from the National Health Service. And with that sort of tripartite funding, we launched the Need for Nutrition Education Project, which has since then been known as NEB Pro, in Cambridge in 2008.
Amazing. And what would you say the main mission of NEB Pro is?
So the mission today is really to look across nutrition knowledge, I would say, from molecules to mankind, and to take the usable knowledge bites from those different domains to try and improve health, well-being, and society. Back in 2008, our main mission was to empower health professionals. That remains an important part of our mission, but today we are involved in targeting not only health professionals, but a very wide range of professionals who form part of the interdisciplinary chain that makes up what is nutrition. So we look at that from the perspective of how nutrition sits at the intersection of, let's say, education systems, health systems, and food systems. But we also look at how to interface directly with policymakers on one hand and members of the public on the other. So I think we have a multi-pronged approach today, but one that stemmed from health professionals and still is heavily centered around health professionals, particularly in some aspects of what we do.
Brilliant. And I guess my description, because we were speaking about this offline, the way I described it, which I think is maybe slightly simplistic, having you describe it now, is NEB Pro links research or nutrition research and nutrition policy and how that influences clinical practice. Would you say that's a too simplistic or even wrong way of describing it?
Oh, no, not at all. I mean, really, if you look at how we work, we start by identifying knowledge gaps in either policy or practice. Then we look at usable research supported evidence that we can synthesize or collate to fill those knowledge gaps. If such evidence does not exist, we actually instigate further primary research in order to fill those gaps. But again, that journey comes back to synthesizing and collating evidence, whether it's primary or secondary, to form educational interventions specifically geared at shifting knowledge, attitudes, and practices, primarily for practitioners, but also, as I said, for policymakers and the public. So really a simple way would be, as you correctly said, to connect research, policy, and practice, but through evidence and education.
Perfect. I love that. I will add the evidence through evidence and education at the end of my descriptions next time I have to explain it to someone.
Thank you.
Recently, it was announced there was a launch of the nutrition program in the medical curriculum, or I'll rephrase that. So the nutrition program in the medical curriculum was recently announced. And I know you have close ties with the AFN and many other allied organizations. How was NEB Pro involved in that?
So the Association for Nutrition, as many will know, is the independent voluntary regulator for nutrition professionals who are not dietitians, but really work across 6 different specialisms, one of which is public health nutrition, which is the specialism that I belong to. And for a number of years, the AFN has been convening what's known as an interprofessional group that consists of multiple stakeholders and experts from different parts of the broad church that is nutrition, or indeed those who would be end users of nutrition knowledge in a medical or healthcare context. So what the AFN interprofessional group did was to take the previous curriculum for undergraduate medical nutrition education, which used to be held by the Academy of Medical Royal Colleges and their intercollegiate group on human nutrition. And they formally updated that curriculum, and I would say transformed it into really a new fit-for-purpose curriculum in line with modern medical education as it stands in the UK, and providing a blueprint to incorporate nutrition at multiple levels of UK medical curricula at the undergraduate stage. And that curriculum was recently officially launched. I had the opportunity, along with colleagues from NEB Pro Global Centre, to be part of the the interprofessional consultative group. And really, in many ways, the launch of the curriculum is a pivotal moment for us as well, as we have been on a sort of 13-year parallel journey during which we've undertaken many different types of action research projects which look at what works and what doesn't, and tests different strategies for incorporating medical nutrition education at an undergraduate level, as well as other levels of medical and healthcare training. So to mark the launch of that curriculum, we also put together a collation of 18 peer-reviewed articles that we've produced over the past 13 years in collaboration with many other individuals and institutions that really provide a little bit of the evidence base that helps to implement the curriculum now on the ground.
Yes, that article is now live on the NEB Pro website, so I'll be sure to link it in the show notes for the listeners to access if they're interested in that.
Thank you.
You're very welcome. It was interesting what you said, about educating medical students around nutrition. I remember early on we were having conversations about this, and there was a certain few which didn't want this to happen because they thought it would take away from the work of nutritionists. And I had the complete opposite view. I was like, as soon as doctors and the medical professions know about the importance of nutrition, they are more likely to refer out to it, or more likely to suggest it to their patients. And I think that's hugely important. And any way that we can reduce the burden on the NHS is beneficial overall and to everyone.
Absolutely. I think the delivery of nutrition services at all levels ought to be seen as a multidisciplinary effort. And there are certain common denominators that individuals from all healthcare professions probably ought to know as part of their minimum knowledge set or skill set. But there are several elements which are more specialized, where it would be more appropriate, say, for example, for a public health nutritionist in primary or early secondary prevention, or a registered dietitian in secondary prevention, clinical intervention, and tertiary prevention, to actually take the reins, but they can only do that if they receive a transfer of care for a patient who will often be seen by either a medical doctor or another type of healthcare professional who wouldn't know to recognize nutrition-related problems or indeed refer onwards beyond a certain point if they didn't have that fundamental understanding and basic competence. So this is really about defining the common denominator, which gives a stronger bedrock for all of the nutrition-related professions to stand on. And quite to the contrary, it does not take away from the remit of any of the professions specialized in nutrition.
Yes, I completely agree with you, and thank you so much for explaining it. Going back to what you said before, what you mentioned before, with regards to the purpose of NEB Pro, I would love for you, if there is a project that you have in mind that really outlines how you have linked policy, research, and education, if there is a key project that you had in mind?
Well, in fact, the flagship projects that we try to utilize across our different regional networks are two that do this at different levels. So one is known as NEP Help, another acronym, the Nutrition Education Policy for Healthcare Practice Initiative. What that does is it attempts to create evidence and resources to shift the default educational policy around nutrition in health systems. So really we use within that initiative not one but a multitude of interconnected projects in order to nudge that policy. And that's very much connected with nutrition in health systems. Now, another flagship project which has become quite prominent of late, I might say, is our mobile teaching kitchen initiative. And in fact, recently, as part of a UK-India collaborative group in Cambridge, this project, along with 7 other groups, won the University of Cambridge Vice-Chancellor's Award. Now, the reason for that is because it uses an approach which actually sits at the juxtaposition of food systems and education systems and looks at ways to shift the default policy when it comes to nutrition literacy and how that can be improved, particularly in groups with an educationally challenged background, and how some of the insights from this very innovative approach of doing all of this using culinary methods can be translated to some of the generic insights that can change our policy thinking, particularly around marginalized populations. This particular piece has now been lateralized to countries outside where this first started, which was India. So recently, this initiative has undergone a first phase in Mexico, and we're knee-deep in discussions with UK counterparts about using this sort of innovation right here in the UK.
That sounds amazing. I mean, you're saying you're spreading it to different countries, but I was wondering, because India's obviously massive, so how are you educating the various different populations, I guess, within India with this kitchen? Is there multiple, or does it travel around a certain region?
Good question. So, country of 1.3 billion people, how does a tiny project possibly make a dent? So our role is not to actually roll out population level mass education programs. Where we sit is really at the sort of juxtaposition of research and innovation. And what we can do is build action research models which bring new insights, and those insights can lead to new or strengthened recommendations. And so it's very important for us to use this small but in-depth project to not necessarily achieve greater breadth ourselves, but to achieve enough depth and collect enough data by asking the right questions and piloting the right interventions to then hand a much more sensitive and specific toolkit of recommendations to policymakers who can then either take the generic elements of those and utilize them in existing programs, which are at mass or population level, or indeed spread and scale the innovation of the mobile teaching kitchen. Who are these policymakers, you might wonder?
Oh,
well, you've
asked my next question for me there.
So they're not just government agencies. Of course, government agencies play an important role, but so does the charity sector, and so do health professionals who have an important voice in all of this. But importantly, industry has a very strong voice, particularly when it comes to food. So in terms of policymakers, we need to look at government agencies, but also third sector and private sector agencies or organizations which are in all of those domains: health systems, food systems, and education systems. An additional piece which we've been quite sensitive to of late is the impact of everything on sustainability and climate change, and therefore that sort of also brings in another element of policy discussion. But going back to your question, so our role is really to take those deep dives, mine the sort of insights and data that then allow those with the big machinery to go forth. And I'm pleased to say that we have been able to have the ear of organizations and agencies who've taken up our recommendations to date, and that process continues.
I mean, this is truly amazing in my eyes. I assume the Indian MTK, I've shortened it already to an abbreviation. The mobile teaching kitchen was almost like a proof of concept, and then you assume that this will be spread out to other countries, and then if the ideas and the education behind this. Well, I say the education behind this, if you can sufficiently educate a population, then that will influence the policy makers to hopefully make a decision, maybe scale it up, or use that idea and almost innovate to something entirely different for a larger scale.
Absolutely. I think it was a number of things that came together in, dare I say, organic fashion. So back in 2015, NEB Pro had a presence at the World Congress of Public Health, which was hosted in India that year. There we pledged to go global, and that was the moment from which we began our transformation to a global center. So that meant starting a series of regional networks in different parts of the world. We now have 12 regional networks that span 6 continents, and between them cover 38 countries. So it really allows us to touch multiple populations and I would say multiple types of development, often with common denominators. So NEPHELP, the Nutrition Education Policy Project, and MTK, the Mobile Teaching Kitchen, represent 2 of those lateral projects, one of which had its origins in the UK, one which had its origins in India, but both providing proofs of concept, as you put it, where the other regional networks can take the proven elements of these projects, but then adapt them to regional context, and therefore create different versions that work in different population contexts. Now, in India, what we were looking to do was simply an exemplar project, which was going to be task and finish. And what we thought we would challenge is this paradigm that those in marginalized populations, by virtue of their economic and educational background, really need to be, in a way, lifted out of poverty, almost in a unidirectional manner. The way we thought to challenge this is to ask the question as to whether we could lift those individuals out of poverty, but give them the knowledge and skills to become nutrition educators through culinary means. So what we managed to do was create a group of champions who became culinary health educators, not only for their own so-called segment of society, but in a way where they can actually impact all levels of society by using a mobile unit to serve up not only meals, but also serve with it a very good, healthy side of health education. And they do that not only for people who are, say, for instance, blue-collar workers, but all the way up to white-collar people like you and I. And so what this does is it challenges the paradigm that the act of pulling people out of poverty, as I said, is unidirectional, because those people are not only coming out of poverty, but they're giving back to society, including the level of society that pulled them out in the first place. And that's really poignant, particularly in low to middle income countries where affluent echelons of society are particularly burdened by nutrition sensitive non-communicable diseases, whether that's type 2 diabetes, obesity, cardiovascular disease. So there's a disproportionately positive impact back to those who are really involved in pulling these people up. Not only that, the mobile unit allows these champions to not only create these template-based meals, which are nutritionally complete and in fact provide a template for discussing health and nutrition matters with the public, but they also get to use this as a micro enterprise and a source of livelihood. And that also makes it self-sustaining, and therefore once such an initiative is off the ground, it sort of has a little bit of an exponential impact that runs on its own steam. And there are lots of generic elements to this whole process which can be lateralized into other initiatives. And it doesn't have to be a mobile unit or a teaching kitchen, but other initiatives that are trying to tackle nutrition and public health problems like those big four that were such a problem 2.5 decades ago and continue to be. And maybe what is needed is not just doing the same thing again if it hasn't worked, but trying new things such as this innovation.
It sounds amazing. And just to touch upon that, you're absolutely right. You need to innovate. You can't just do the same thing over and over again and expect a different outcome. Isn't that something like the definition of madness? I don't know.
I believe so.
Yeah, and you mentioned the sustainability, which is a really interesting element. And it makes a lot of sense. But I don't understand, or I haven't linked the way that people learning about nutrition education and how to cook and culinary skills, I should say, and how that would lead to employability. I guess because you're teaching them how to cook and therefore they could become a chef, or is there other ways that you envisioned or had in mind?
Absolutely. So using culinary methods to teach, particularly in this particular innovation or intervention, means that we use a Sodoto approach, which stands for see one, do one, teach one.
Right.
A Sodoto approach and its effectiveness can be measured through KAP studies. So that's the collection of data around K for knowledge, A for attitudes, P for practices.
Mm-hmm.
So we look at whether the see one, do one, teach one spiral approach of learning augments knowledge, attitudes, and practices. But if you think about it, it's also like a funnel, because the people who are essentially teaching one at the end are inviting others to see one, who will then do one and teach one. And so there's a cascade. What happens in this process is we have looked at a couple of educational psychology constructs, namely mentalizing skills and cognitive flexibility. And what we seem to be finding, and we're still looking at data in this area, is that using a vocational method of teaching concepts, not only the cooking skills, but the nutrition knowledge that goes with it, or the health knowledge that has to accompany it, it circumvents literacy barriers, and even people with lower baseline cognitive flexibility and lower baseline mentalizing skills, they can actually achieve a greater shift in knowledge, attitudes, and practices, perhaps compared with more traditional methods of training. Also, it's really interesting to see that there's a shift in cognitive flexibility and mentalizing skills through this sort of process. Now, if you are familiar with pedagogical methods, you'll know that theory of mind in most education systems develops within the sort of first 5 years of life, give or take. And cognitive flexibility and mentalizing skills are important constructs of theory of mind. And this is why the early years curricula focus so much on learning through play and doing things with our eyes, ears, and hands. So things which are tangible. And so this is very much a method of returning to that sort of baseline and trying to reprogram learning from a place where one is able to take up new knowledge and new skills without having to navigate all of the literacy barriers that sometimes go with formal education. How is this connected to livelihoods? So yes, people can become chefs, no doubt. They can become entrepreneurs by learning how to make low-cost, sustainable, nutritionally very high value and complete meals which are tasty and also easy to prepare. So that makes for a very good food business, or a micro enterprise as we call it. Mm-hmm. But very importantly, because of the knowledge of nutrition and health concepts, these individuals can also become part of the auxiliary healthcare workforce, particularly focused on diseases related to nutrition or indeed food safety.
Right, so there's a lot of elements there. Thank you very much for clarifying that. It makes a lot of sense. And I guess something which I can't get out of my head is the idea of, when you're giving this nutrition education, serving a delicious meal at the end of it makes the whole lecture and piece much more appetizing, excuse the pun, but, you know, much more digestible. Again, another pun. But the idea just that it's much easier to assimilate, and people will be much more engaged if you're kind of making the meals and showing them how healthy it is in a practical way. I feel maybe that's sometimes lost in conventional teaching.
I think it can be, but also if you think about it, we eat meals on plates or whatever other utensil we use, but there are certain kind of dietary patterns that we follow. Those patterns, if you break them down, are comprised of a series of recurring plates. If you think of each plate as a template, and let's say that roughly in the cycle of a week, a dietary pattern undergoes recurrence. So what you would tend to find is that there are, if you lined up all of the plates, so let's say for argument's sake, we eat 3 meals a day, 7 days a week. So let's say there are 21 plates. So let's line them all up. So pictures of the plates of what we eat. So what we'll tend to find, if we put the plate that is most ideal, that adheres the most to, let's say, a recommended dietary pattern, if you find that one plate that fits that the best, put that in the middle, and then arrange other plates on either side of that as they begin to deviate from that so-called ideal dietary pattern, you'll actually find, let's say that, for those people who are free-living, healthy individuals, there's a sort of leeway where the plates towards the two tail ends tend to be somewhat different from the ideal dietary pattern. And then if you put the overlay of risk factors or disease on that, the room for movement becomes less. Now, if you think of that sort of paradigm, it becomes easy to educate people using a series of menu templates and pictorially lining those up and showing them what sorts of leeway you can have for a healthy, free-living individual versus those who have, as I said, the overlay of disease, underlying conditions, and risk factors. So seeing that, visualizing it, and then being able to replicate that in a kitchen setting, demonstrating it to others whilst talking through it, is a lot more powerful than being able to write everything down and sometimes simply extract the numbers and then throw those numbers back at people saying, these are the different percentages of X, Y, and Z that you need to conform to. I hope that makes some sense.
That definitely does. I've never really heard it described that way, so thank you very much for outlining it. Just to pivot slightly onto something which I think was and still is in everyone's minds, which is the COVID pandemic. COVID affected everyone very differently, and that included how people were working, and it seemed, to me at least, that NEB Pro really shifted and I guess stepped up to the plate in a way, and even created its own COVID microsite and spoke about how nutrition related to COVID, etc. And I thought, looking back on this, that this was maybe slightly outside of the remit of NEB Pro, but you might tell me this is completely wrong, this is why you're here. So what could you please describe or explain the premise behind this?
Sure. So it is and isn't outside of the remit. I mean, broadly, the kind of 4 things we do are training professionals, implementation, primary research, and addressing inequalities. Now, within all of that, as I was saying before, we start the process by looking at where the knowledge gaps are on the ground. Mm-hmm. Now, obviously, when the pandemic started, there was a massive knowledge gap in relation to everything to do with COVID.
Yeah.
But, of course, there are many highly able groups who have done wonders this past sort of year and a half in in cracking many of those unknowns. But really back in March of 2020, we didn't see a focal point for the convergence of nutrition knowledge related to either the primary or secondary prevention or indeed intervention in terms of COVID-19. So we put together a dedicated nutrition and COVID-19 task force. We did this within a few weeks of the pandemic being declared. And initially that task force met weekly, and nowadays we meet monthly. In fact, we will be meeting later today. And that task force is, again, a multidisciplinary group. So there are doctors, dietitians, nutritionists, other healthcare professionals, as well as others from education and policy, who are able to provide a continuous horizon scan in relation to any usable quality nutrition evidence and how that can be mapped either to primary prevention in terms of specific protection or health promotion, secondary prevention in terms of early detection and prompt intervention, but what the nutritional considerations are alongside other medical and public health measures, and also tertiary prevention, particularly in terms of management of what's now known as long COVID. There's another piece also that a couple of other pieces, I should say, that we've been very interested in under the remit of this task force. One really in the wider world on how COVID has impacted food and nutrition insecurity. And the other one in the acute clinical context and how nutrition can potentially modulate clinical outcomes in either intensive care or ward-based settings alongside other standard medical approaches. So we teamed up with our flagship journal, BMJ Nutrition, Prevention and Health, from the outset. Mm-hmm. And this enabled us to do two things. So three, in fact. So one is we commissioned a special collection in BMJ Nutrition on new evidence underpinning nutrition and COVID-19. And we have a whole plethora of peer-reviewed articles in BMJ Nutrition across all of those domains that I previously described. And a few of those contributions are from us, as we are also researchers. But many of those contributions are from further afield and from geographically diverse groups. And then on top of that, what we've done is, as you pointed out, put together a microsite, which is updated on a monthly basis. And that microsite looks at not only what BMJ Nutrition is publishing, but all usable evidence in different categories around that, guidelines segmented by the different regions where we're operating, but also segmented by different topics. And of course, we can't talk about nutrition in isolation. So one part of our microsite looks at the big picture, so public health and prevention at large, and another part is dedicated to nutrition resources. The third thing which we have now done for about 9 months is we have a digital knowledge hub known as ICANN, the International Knowledge Application Network Hub for Nutrition. What that does is every month it actually takes the material from the microsite and presents that as an evidence collection for online discussion. So the ICANN platform is open to one and all from anywhere and everywhere to register. It's completely free of charge. And what we do through that is the evidence collections are presented in the form of evidence maps, which are updated on a month-to-month basis. And as people leave their comments and questions on the discussion boards, that enables us to look more closely at how the evidence collection can be made usable, not just in the context of the UK. As we're headquartered here, there's sometimes a little bit of a bias, particularly around the way we do things in this part of the world. But as we're a global centre, it's really important for us to look at whether these evidence collections are usable in far corners of the world, and this digital platform enables us to have that multi-way dialogue. So I think, going back to your question, was it in our remit? So we never saw infectious diseases as part of our remit. We did see part of our remit being filling knowledge gaps. Now, having done this 18 months on, whatever the future of the pandemic, I think that as there's a critical mass of work in this area, we intend to continue our investigations into nutrition and COVID-19 for the foreseeable future in the form of action research and knowledge translation.
Perfect. Well, you have a mountain of work that you've completed, and I will link to as much as I possibly can, including the microsite and the other projects that you've outlined. Hugely, hugely fascinating. It certainly has been to follow your journey anyway. I know we're running out of time, and we've got the last 3 questions that I ask everyone that comes on the show. But before I ask them, can I ask you how people can get involved with NEB Pro if they would like to?
Sure. So the NEB Pro Global Centre is a research-intensive think tank, and generally we have membership by invitation, which means that we invite individuals and institutions to become members, particularly if they're making a recurring contribution to one or more of our existing projects and initiatives. So the best way is to look at the Our Work section and the About Us section on our website, and to get in touch with info@nedpro.org.uk, or with myself, and I'm at s.ray@nedpro.org.uk, to see if you might wish to make a contribution, particularly if that's an ongoing contribution to one or more of our projects or initiatives. However, there are 3 children that the NEB Pro Global Centre has. They're all 3 years old. They were all born in 2018 during our 10th anniversary. One is our flagship journal, BMJ Nutrition. So you can get involved by publishing in the journal, but also it's an open access journal. You can write response articles which don't cost anything, particularly looking at published articles and submitting your responses, which, if approved, will be published. Our other children are the International Academy of Nutrition Educators, which we co-manage with the Society for Nutrition Education and Behaviour, Monash Nutrition and BMJ. And that is a subscribing membership academy, which provides a whole raft of benefits, but it provides a career pipeline for those who see themselves as nutrition educators, going from associate member to professional member to fellow and so forth. That academy provides a one-on-one mentoring scheme, monthly webinars, journal clubs, and a whole bunch of other CPD benefits. All subscribing members of the academy automatically have the opportunity to be more involved in NEB Pro projects. And finally, the ICANN, International Knowledge Application Network 25, as it's called. What we're trying to do by 2025 is really put key evidence collections on there. I've spoken about the COVID-19 one. We have a cardiometabolic evidence collection and various others to follow. That's completely free to register on. If you go to icann.global and be part of the discussion. And from those discussions will be database decisions. So be part of that difference. And those are the ways in which you can be involved.
Perfect. I'll link to everything in the show notes. Thank you so much, Shumone. And on to the last 3 questions before we both have to dash. And the first one being, what is the most impactful health change that you have made in your life and why?
So we hear a lot about lifestyle medicine nowadays. And broadly speaking, I guess the 4 pillars of that are nutrition, sleep, mind, and movement. I'm still working on the movement bit, I must confess. And I've certainly had a lot more sleep since the pandemic started, and we've all been working virtually. We are a fully virtual digital global center. But I think the most impactful one has been mind. And many years before colleagues and I founded the NEB Pro Global Center, I had the opportunity to train in mindfulness and meditation. And almost 2 decades later, I looked back to find that, in fact, many of those little things have all added up to help navigate the big things along the way. And that led me to also undertake some refresher training in mindfulness and meditation. And I would say that out of those 4 pillars of lifestyle medicine, if you call it that, that aspect of mind has been the most profound for me in terms of a change I made probably a couple of decades ago, and one where I'm still refreshing, still learning, and still continuing to make small changes that I hope ultimately can make a big difference. Sometimes incognito, but big difference nonetheless.
Brilliant. I love that one. The second question, how can healthcare, and we'll have to adapt this one, I think, but how can healthcare become more integrated with the kind of modalities that we spoke about today? But I think we can integrate this and specifically talk about the kind of projects that you've outlined today.
Well, I'd like to think that what we provide are various examples of implementation of nutrition in healthcare. And if you think about the implementation pathways, they often can follow something known as the knowledge to action cycle. Now, there are certain actions that are needed in healthcare, and there are certain knowledge sets that are required behind those actions. And really, it's about looking holistically at both the knowledge and actions, not separating nutrition versus another discipline versus another, and then finding those pathways that allow those holistic knowledge sets to result in holistic actions. And it's all about defining that path in between. And I do believe we provide a few examples of that.
Perfect. Thank you, Shumone. And finally, can you please provide the listeners with 3 quick tips to help improve their health and well-being from today?
Well, my three tips, I almost said tricks there, but they're not tricks at all, are really to live, laugh, and love. And I think that that sounds a little bit fluffy, but I would say that really thinking about the intention behind everything that we do, asking ourselves, why we're doing it. Do we really need to do it? What difference is it going to make? But also along the way, to actually not take life quite so seriously, to start with the intention of doing something that is necessary, worthwhile, enjoyable, but also being flexible and really thinking about impact as the destination, whatever level of impact that may be, whether that's explicit or implicit. So intention, implementation, impact along this pathway, tread it lightly, live, laugh and love along the way, and don't take life too seriously. That can lead to a massive improvement on health and well-being by removing a lot of the sort of smaller stresses that often add up on a day-to-day basis.
Shumone, I absolutely love that. I think that's brilliant. Those would probably be my 3 quick tips as well. I have to say, I've thoroughly enjoyed this. It's amazing to see everything that NEB Pro and yourself are involved in. I'll link to everything that we've discussed in the show notes. I want to say thank you so much for coming on the show. And I really, really do hope that we can do this again soon.
Thank you very much. I've enjoyed it myself, and really looking forward to hearing all your other podcasts and what a rich tapestry this makes. Thank you for doing this.
Thank you, Shumone. Thank you for listening to the Functional Health Podcast. You can find links to everything that we talked about today in the show notes. If you have a second, please consider leaving a 5-star rating on iTunes. It really does make a huge difference and helps get this valuable information out and reach more people. Don't forget to subscribe so you can stay up to date and know whenever I release a new episode. You can connect with us on Instagram, Facebook, or our website, and all questions are welcome. As always, thanks to Josh Aurelia for all the editing, and thank you all for your support.